On April 8, 2009, during my internship at a Saudi Arabian hospital in the orthopedic ward, a 75-year-old male, John, was complaining of severe pain in his left leg. John was also experiencing shortness of breath and chest pain following an 8-hour drive with no stopping. John was a chronic smoker. John's vital signs were the pulse 89, blood pressure 138/89, temperature 38.4 centigrade, and respiratory rate 28 breaths per minute. On his arrival at the ER, after they discovered the deep venous stasis ulcer, the orthopedic team admitted him to the ward and ordered 5 days of bed rest. I looked at his medication record that included 3 antibiotics and pain medications. The next day was my morning shift as an intern, so I went to give John the antibiotics as prescribed. John told me that he was experiencing cramping and burning sensation in his left leg. Well, I asked myself many questions. When did he last get his pain medication? Is it a DVT? Has he had this cramping before? Is it muscle spasm? I took John to the medical imaging department for a Doppler ultrasound at 10 a.m. and returned at 11:30 with the results of the ultrasound that were negative for DVT. Following 2 days off, I had an afternoon shift. At 4 p.m., I received John back in the ward after 5 hours of left leg wound surgery. John had the following attached: PCA of morphine, IV fluids, and 4 exogens. The physician ordered continued IV antibiotics, get an X-ray, and FBC. During the morning shift, 2 days later, I entered John's room at 10 a.m. to find him short of breath and holding his chest. Engaging assistance from other staff, he was starting on oxygen. A 12-lead electrocardiogram was done, blood was sent to the lab, vital signs checked, and a mobile chest X-ray done. The blood results demonstrated respiratory alkalosis, and chest X-ray showed that the central pulmonary arteries were prominent either from pulmonary hypertension or the presence of a clot in the arteries. The next day, I took John to the medical imaging department for a VTE scan. The radiologist was unhappy with the results, confusion, and suggested an additional diagnostic test. The patient had a pulmonary angiogram that showed a blood clot in his lungs. John started treatment to prevent further clot formation. The treatment was anticoagulation therapy, heparin, and warfarin. John was finally recovering, but it took many diagnostic tests, many medications, and a hospitalization that exceeded 30 days. Orthopedic patients need to be assessed for risk factors that lead to DVT and PE instead of making them suffer unnecessarily. If orthopedic patients at risk receive education to prevent the development of DVT and PE, the rate of extensive hospitalization will be reduced, the cost of care and medication will be less, and the death rate will be decreased. According to January 2011, nurses have a vital role to play in VTE prevention. They can decrease the risk of VTE through risk assessment, provide education in the use of thromboprophylaxis, and educate patients in the importance of mobility. The purpose of this evidence-based change practice is to provide nurses with the best strategy to reduce the risk of harm to orthopedic patients through risk assessment, thromboprophylaxis education, and the importance of mobilization. The EBP change will enable nurses to build a successful interprofessional relationship and effective communication with patients and their family by providing appropriate education and support of self-management practices.
Created using Powtoon.